name is Ravi Gadan and today we'll be talking about effective clinical and practical skills teaching. There's a disclaimer. Skills teaching or even large group teaching or small group teaching, a lot of it you are already doing. So whatever I am going to sort of talk about is mainly naming those methods. Okay, so at the end of my session you may say that I have already been doing this and I know you are doing this. It is just about naming it. That allows easy reproducibility and it also allows easy communication between two groups, right? Okay, so this session would have, first we'll talk about the objectives, then we'll see what are, what is a skill and what are various types of skills, what are current trends, what are problems in skills teaching, what is a learning cycle and what are the principles, how do we learn, where all can we teach clinical skills, and finally how to teach clinical skills. Actually, these are the 6 segments, but these two are the main the crux of my talk. So let's look at the objectives. At the end of this session, participants means you will be able to enumerate various challenges that we face when teaching clinical skills. You'll be able to describe skills teaching and the principles. What are what all settings can you really teach clinical skills into, different methods, and finally a bit about simulations and skills lab. So if we see what is a skill, can anyone just shout out what do you mean when you hear the word skill, even out of medical context, just anything? Ability to do. So like a particular thing, not really anything, but a particular thing.
Ability to do a task efficiently.
Exactly, yeah. So pretty close. So a healthcare professional, it is said that any action by a healthcare professional who is involved in direct patient care, which has a measurable impact on the outcome. So basically it is ability to do something but with a predefined outcome. So if I wish to bake bread, then I have to define that outcome first. Then I want to bake a cake or bake a bread, right? And that is how I'll then go about the process. There are 4 chief types of skills: cognitive skills, then psychomotor skills. Cognitive skills are not just knowledge, like knowing what are the causes of ischemic heart disease, but it's more like analytical skills. So consider a student receives that some serum markers are elevated. He is able to analyze that what might be going wrong with the patient right now. It is not just about whether the markers are above the roof or not, but he is also able to analyze it. So that is what cognitive is. Psychomotor skills are mainly manual dexterity, like someone is doing a venesection, drawing blood, putting in catheter, putting in NG tube, okay, or maybe performing an angiography. Everything is a manual dexterity. Communication skills and team skills. Now we need to understand that even at the base of psychomotor skills, cognitive skills are already included. So when someone is attempting NG tube insertion, certain amount of knowledge is already required. So they are not like really very exclusive, but they still have these 4. And chiefly we are going to talk about these 2. So what are the current trends in skills teaching? So if you see this picture from Karate Kid, or if you see this blacksmith, or if you see this from Star Wars, this is reasonably the current trend in skills teaching. So can anyone say what is it? What model it is? Yeah, 1-to-1, or rather master apprentice model, right? So that is the current trend. It says that you see one and then you do one. The observations by the observer are usually passive, and just because someone knows about a skill and someone has seen it being performed doesn't mean that person will be able to perform it. Again, a disclaimer: if there is one master and one learner, it may help. But medical education, this is especially focused on undergrads. So we have one master and 250 learners, right? So then observation, just observing someone do doesn't really help, right? So that is why we require other methods. So what are the current problems in skills teaching? There is lack of clear objective. As I told you, ability to do something, okay, like these steps I need to take, but to attain which objective? So if you see, this session has an objective. We have a collective objective for this workshop. So that is how when there is a skill session that is devised, it has to have a clear objective that at the end of that session, someone will be able to perform it or demonstrate it at whatever level, shows how or perform. Large number of students, of course, teacher has no time, there's a lot of clinical workload. Students are not interested specifically for undergrads, there's more focus on MCQs, so rather than learning clinical skills, they're more focusing on MCQs. It is not explicitly included in the curriculum. Usually the lectures are there. Theory, bhanavi devani. But clinical skills is sort of on a passive and auto mode. Methods are also not standardized. When they are not standardized, I cannot communicate. Like if I'm talking to a colleague of mine, I can tell them that aaj 5 students છે એમને મેં OMP ભણાવી દીધું છે, like OMP કરાવી દીધું છે, or I have taught them OMP for right iliac fossa pain. So then it will immediately get communicated. But if I say that case presentation લીધું તું, so there will be varying degrees of differences between me taking a case and that person taking a case, right? So methods are not standardized, there is inadequate supervision, little opportunity for reflection and discussion among students and students with faculty. And clinical teaching is usually not given high priority. As I earlier also said, there are mainly lectures and theory is given importance. In spite of this, why teach skills? We all know, but still there is growing mistrust between patient and doctor. We need that performance emphasis is increasing all domains, not just medicine, but even other domains of life. If you see any other profession, you would expect that there has to be a certain level of competence in whoever has just finished the training. People now understand far more, as they are coming to doctor for the second opinion directly for the first time because they already know their diagnosis and they are just here to confirm it. And finally, enhanced patient rights because of the Consumer Protection Act and of course the Mediclaim which is being penetrated right now. So what's a learning cycle? So if you see, when an undergrad enters MBBS, we'll take an example of intubation. So that undergrad does not know how to intubate, but he also does not know that there is something like intubation. Okay, so he is incompetent to intubate, but he is also unconscious of his incompetence. He's like, out of a voyage nahi hai, right? So then what happens is, with knowledge, awareness, he goes to the second phase. The second phase is conscious incompetence. So he comes to know, okay, kaik intubation jevu hoy, but મને નથી આવડતું. There is something like intubation, but I don't know what it is, right? Then you train him, and after training, he becomes conscious and competent. So what is conscious competence? So conscious competence is mainly being able to perform a task or a skill, but with certain conditions. So it's like if I have learned intubation just now, I would say mouth opening proper હોવું જોઈએ, કોઈ દાંત હલતો ના હોવો જોઈએ, અને હું જ્યારે કરતો હોઉં ત્યારે મને કોઈ બોલાવતા નહીં પ્લીઝ. અત્યારે માથાકૂટ ના મારે intubate કરવાનું પેશન્ટ, અરે આ સેલ કામ નથી કરતો, everything. So that is conscious but competent, right? But the same person, when there is enough practice, after 500 or 1000 intubations, can deftly intubate a roadside patient in a traffic accident in the midst of an emerging chaos. That is possible, right? I mean, you have seen that. It's almost an art, right? So that is when the person enters the domain of unconscious incompetence, okay? But the cycle, it's a cycle, right? So it cannot stop here. It has to complete. So then if the same person loses interest or rusts out, he enters again in the stage of unconscious incompetence. And when you cross this bridge, your colleagues will know. You will not know. Right? I mean, of course. Okay, there are skill acquisition principles. There was just one disclaimer that this is all adapted from Peyton 1998. Skill acquisition principles are simple. First, outcome has to be defined. I want to bake a bread or I want to teach vivisection, right? So outcome has to be predefined. Standard approved process of acquisition is clearly outlined. In fact, you need to actually put every single step, like if it is a vivisection, then where the session will be taken, which is the first step, like how will opening of the wrapper and handing over how will the patient take the trainer take the syringe, how will he take the needle, how will he insert it, how will he clean the area, everything, every single step has to be predefined. Learners are then provided opportunity to practice and finally they self-assess. So if you see, there are 4 main steps: outcome is defined, process is defined, opportunity to practice, and finally that self-assessment. This is taken from skills training module of MCL 2019. So where all can we teach skills? So it can be workplace or it can be in the skills lab. So in workplace, there is OPD and Evening Clinic where you can teach history taking skills, clinical examination skills, even venesection, blood pressure measurements, right? Hospital wards are great for deepening the history taking skills, but there are also minor procedures, venesection, blood drawing, NG tube insertions, Foley's catheterization, even ECG taking, right? Emergency room is where they can be taught about suturing or prime management of a trauma patient or management of any particular emergency, starting IV fluids, etc. Operation theatre regarding the basics of what is asepsis, antisepsis, and what role does it play in for most medicine branches. And community centers are great for especially communication skills and actually knowing that whatever they are being trained for, how does it really manifest in the society? Who are they really working for? And that connect is usually missing unless the student actually walks up to the community health center. So direct contact with patient is important for non-technical skills, especially the patient should be briefed. I mean, I'm not sure if you have case presentations here like bedside, but at least we need to brief the patient that there's going to be 5-7 people surrounding you, especially with undergrads. It's sometimes 20-30 students who are like surrounding the bed. The patient may become slightly apprehensive, and then he would not release the history the way he should. And then we would believe that the student was not able to draw proper history, right? So we need to ensure that this patient is relaxed. Just you'll be fine. Ideally, not more than 5 students per patient on bedside teaching, and the facilitator or the faculty, whether it's resident or faculty, he should ensure that everyone takes part equally. When you see this or this, what comes to your mind? This is, simulation, perfect. This is HoloLens actually. This is Microsoft product. So this is augmented reality, right? Because it's like the physical reality is there and it's being augmented. This is pilot training simulation. So skill lab or simulations are also known as skills training or simulation training center, and clinical skills ideally should be practiced first in skill stations or on simulation, and then only the student should be allowed to see a patient. In fact, if you see BJ Medical College, any one of you is passed from here, I recently noticed that we actually have a bridge from college to hospital, and that bridge is actually skills lab. Now it is not truly a skills lab, but then that is what we say. So skills lab is the bridge between basic science and ward clinical teaching. Simulations are basically approximations to reality. They are approximations to reality. And simulation need not just be mannequin, right? You will be able to see that there are many other variants of them. The immediate reality, they offer almost limitless opportunities to fail, and that is how learn. And finally, they also provide corrective feedback. Basically, it is a standardized process, and you can, of course, give corrective feedback to each student. There is decreased risk to patient. It enables deliberate practices. Deliberate practices is a total term, so it's not deliberate practice like two separate terms. It was coined by Erickson. He was a psychologist, and it's like deliberate practice, hails from the idea that when you want to learn a skill, you first want to break it down into a lot of parts and then practice each part separately with immediate feedback. That is what deliberate practice is. And that can be achieved only through skills lab. Technical as well as non-technical skills. Non-technical skills are communication skills. Communications within healthcare, right? They are non-technical skills. So if you have a simulated patient or if you have a standardized patient, these non-technical skills as well can be practiced. Assessment is objective and there is reproducibility. So you can have mannequin as a simulation which can be low, medium or high fidelity. If you know about a particular mannequin which is known as SIM-MEN, S-I-M and then M-A-N, so SIM-MEN, simulated men, and Simman is, that mannequin, you can not just intubate, it breathes, it blinks, it moves its eyes, you can have a high blood pressure, you can inject, you can draw blood, you can do cricothyrotomy, right? It's of course it's an entire machinery within itself. So there are various levels of fidelity available in mannequin. Virtual reality, which is like when your reality is totally replaced, that can as well be used. Simulated environment. A large scenario is completely enacted, whereby maybe a scenario of road traffic accident has been made, and 5 students are sent there to assess it, and that is how they learn. Like there's an actual ambulance with its sirens ringing, or there are firemen, and then there is a 3 or 5 trauma patients who are there. So entire environment can be simulated as well. Cadaver skill lab, we all know, for human cadaver. Living animal labs are fairly common, especially for post-surgical training, because you don't want them to practice a particular surgery on humans directly. Standardized patients are real patients. Okay, so standardized patients are if you have a case of chronic obstructive pulmonary disease. Now it's not going to go away. It can just be controlled. If they give their consent that I am willing to come, then you can call them. You can even teach them how to give history, and then you can ask a student to go and learn that. Simulated patients are actors, so they are not patients, but they are taught that how will you really enact this particular illness. And role plays are slightly less formal method of clinical teaching. Even a teacher, I can be a patient and I can give history, or maybe some peer-to-peer learning can also as well take place. Finally, how to teach skills. So there are 4 varieties: cognitive, psychomotor, communication, and team, and I told you we'll be looking at these 2 mainly, and just briefly touch upon these 2. So if you see cognitive skills, it's also known as clinical reasoning. It is best taught during clinical encounter. Clinical case presentation is one part. Case-based discussion, when it's a group discussion that happens where you have just you've written down everything about the patient and then you're discussing on it. Clinical problem solving exercises can be there, and finally there can be structured case presentation models like OMP or SNAPS. OMP stands for 1 Minute Preceptor. So we have Parjanya is an intern in our unit, and me and him, we both will act out this OMP for a particular case. Okay, so I'll just go through what it is right now, then we will perform. Okay. So OMP stands for 1 Minute Preceptor. It is one of the method of structured case presentation. I told you earlier you are doing this, but now we are just adding a name to it and maybe providing a bit of skeleton to it so that you can reproduce it at multiple levels. It makes every minute count, and that is why it is the name. It checks 5 micro skills, takes about 20 minutes in total. So about 10 minutes where the student will spend time with the patient. That's 10 minutes about history taking. And 10 minutes where the patient will be sent, and then student will come to you, and then finally you both will spend 10 minutes in the encounter. So if you see in that 10 minutes of preceptor and student encounter, about anywhere between 3 to 5 minutes can be the presentation when the student only will talk. Step 1 and 2, which I will come in a moment, will take about 1 to 2 minutes, and finally 3, 4 and 5 will take about 2 to 3 minutes. So that comes to about 10 minutes. So I'll enlist all 5 steps, then I'll call him, then we'll go one by one, so you'll make it clear. So first step is asking for a commitment. So once he has presented the history in around 2 to 3 minutes, I'll tell him, so what is your probable diagnosis? What do you think is going on here? So I'm asking him to commit to one thing. He cannot be vague here. He can commit to 2 either. 2 also, but I'm asking him to commit to something. Probe for supporting evidence. So I'll ask him, why do you think it is? When you ask them, right? So that's there. Thirdly, now the teacher will speak. At this level, the role of the student goes over. Now step 3, 4 and 5 are only teacher-centric. So I'll teach him some general rules. See, when you get such a case like that, reinforce what was done right. If there was anything that you think he was on the right track, partly even, then you can reinforce that, and finally you can correct mistakes. Okay? So, Parjanya, can you come? Okay, so you can take this one. It is not a daily one, but it's, as I told you earlier, it makes every minute count. And that is why it is named as one once. And usually it is also said that it is a slightly mainly focused on undergrads, and it is also teacher centered. SNAPS, on the other hand, is a slightly advanced method which is mainly learner centered. But this is just because it makes every minute count, and they say that this can be completed even when you are even in a busy OPD. If you have maybe 10 minutes by the time the student takes the history, those are 10 minutes. But then you can come and just because those 5 steps are clear in me, I can do this. Honestly, I told you earlier, you're doing the same thing. It is just about naming. Naming and stepping it. So we don't miss out on anything, right? See, because we are, the way media is, sort of engulfing us all the time, we require more and more standardization at all levels, right? All levels, not just patient management, but also student teaching, so that we can actually compare. કે આ સ્ટુડન્ટ એવું કે મારે એક OMP કરાયું હતું તો પછી પેલો બીજો સ્ટુડન્ટ કે પેલો કે મારે પણ એક કેસ પ્રેઝન્ટેશન કરાયું, you don't know what depth was there, right? Okay, shall we start?
Mrs. Shelja is a 40-year-old.
He's presenting a case. You can look at me, no worries.
Mrs. Shelja
Closer also.
Yeah. No, I'll actually be setting each step, that's why. Start.
Mrs. Shelja is a 40-year-old female who presented to the OPD with a lump in her right breast since she has noticed while bathing before 15 days. The lump is not painful and seems to be static in size since she has noticed. She has no nipple discharge or changes in the skin of her breast. She has no other significant complaints. On her past history, she is not a known case of any major illness. On family history, her mother has diabetes mellitus. There is no significant family history that needs to be mentioned here. Menstrual history, the cycle is regular of 3 days, occurs every 28 days with no other complaints. She is a mother of 2 healthy living children and there is no history of an abortion or miscarriage. On examination, she is conscious, cooperative and her vitals are within the normal limits. On local examination, a lump of approximately 3 by 3 centimeters is palpated in the upper middle part of her right breast. It's non-tender and temperature is normal. It appears freely mobile within the breast tissue. Skin and nipple areola complex are normal. Ipsilateral axillary lymph nodes does not reveal any significant changes. Rest of the systemic examination is normal.
Okay, so what do you think is going on with this patient?
Sir, I think it is a case of fibroadenoma because it is mobile and there is no associated pain. Had there been so, I would have considered malignancy in my differentials too.
Okay, so why do you say that this is fibroadenoma?
Sir, she is a 40-year-old female with a small lump which is mobile. There is no fixity to skin, pectoral fascia or muscles. There is no associated complaint of pain and on local examination there are no palpable lymph nodes that can be examined. So it more goes in the direction of a benign etiology.
Alright. See, Parjanya, when you look at a female who is bordering her middle age, the chief concern, in fact, why she has come to you is because she is worried about it being a cancer, right? So, you should always keep malignancy as your first diagnosis, right? Because missing out on a malignancy would be catastrophic, right? So, then you can of course go for investigation, it can be ruled out. But as a primary diagnosis, you have to keep that in mind. Secondly, early cases of breast lump, breast malignancy can be mobile, and even if the axilla may be pretty clear, right? So that is there. Now I do believe that you had malignancy in your, as your second differential, which is appreciated. But at the same time, I believe what you missed out on was details around the history, whether what was the menstrual history like, what was the age at menarche, what was the age when she had her first child, or also, you could have gone in details of whether the mother, the sister, or the mother's sister, that is maternal aunt, any one of them had similar complaints. And I think oral contraceptive pill was also one thing that you missed out on, right? So do you think you can really read up around the risk factors for breast cancer and maybe how does it present. So does that work for you? Yeah?
Yes, sir, I will.
Okay, thank you, Padma. Okay, thank you.
Can you please?
Okay, so that was OMP, right? I mean, we rushed through it, so in order to finish it in 4-5 minutes, but it takes about 10. In contrast, if you see SNAPS, it's an acronym for 5 letters, so it is also similar to what we do, but it is mainly learner-centered. So mainly learner will only speak with a brief introduction by the preceptor. So first step is, of course, the student will come and summarize the case. He'll narrow the differential diagnosis that I think this can be 1, 2, or 3. Analyze the differential, why I think this is 1, 2, or 3. Now this fourth step is where the learner will probe the preceptor. So he will ask, do you think I have missed out on anything? Do you think I should have considered something else? Right? So that is probe the preceptor. So that's 5. Then plan management and finally select a case for self-directed learning. So at the end, the learner himself, here I suggested him that you want to read up on what is the presentation like and what are the risk factors like. But there, the learner himself would pick up a session for a topic for self-directed learning. So this is SNAPS. Other methods are reflection and metacognition. Reflection is a session within itself, and metacognition is thoughts about thoughts. Okay, so it's like knowing how a person learns. So that is also a topic within itself. Let's go to psychomotor skills. Psychomotor skills are best taught by Peyton's 4-step method. Okay. It is usually considered superior than simple instructions, especially in medical science. I mean, it has been evidence-based and it's been proved. There are 4 steps. We are also going to demonstrate Peyton's. I'll just rush through them, then we'll again go back and see each step. So first step is demonstration. So demonstration is where the trainer or the demonstrator, instructor, will demonstrate the skill at normal speed without saying anything. So I have a learner in front of me, but I will just perform the skill. The learner just sees it and I will perform it at a normal speed. Deconstruction is the second step, where I demonstrate the skill, slower speed, breaking it down into multiple steps and narrating each step, or rather describing each step. So demonstration, deconstruction. Third step is formulation. Again the instructor performs the skill, but this time the the learner will dictate the instructor. So I will not do it by my own. I'll just say, tu ke pramanam kar. Okay, so that is where I will be just obeying whatever he tells me. So there is some leeway around. You can even, if you think that he is going totally haywire, you can rectify it. Ek minute, you forgot this step. But that is what it is. And final step is performance. This is where the student will demonstrate the skill, but he will also describe each step. So 3 times it is to be performed by the instructor and 1 time by the student. Well, shall we do it? So we have Dr. Prakriti Patel, she is the Associate Professor in Pharmacology, and you know that. So Dr. Ashray and Dr. Prakriti will demonstrate this skill. Dr. Ashray is the instructor. Am I right, ma'am?
Yes.
You are the learner.
I am a student.
Yeah. So this is. Do you think you can want first one injury, because in step 1 he is just going to perform it, so we will not require mic. In step 2 we will do it.
The task is how to withdraw drug from a wire. So first I will just demonstrate.
So he has just performed it. He didn't spray anything and he did it at his usual speed. Okay, now the second step, it is deconstruction.
So first we will sanitize our hands. We will also disinfect the tip of the wire. It's disinfectant. And first we will take out syringe and needle. We have to make sure that we don't touch the tip of and nozzle of the syringe. We just take the syringe out via its back end. Okay? And then we again take a needle out while making sure that we don't touch its back end. And we just insert the needle on the top of the syringe. And we have to take out the scab. We will take air as much as we want to withdraw the drug from wire. And this air we will insert into the wire so that it will create a positive pressure inside the wire. Then we will withdraw the drug, whichever one we want to withdraw.
So this was the second step. Now the learner formulation, where the learner will dictate each step and the instructor will do so, rectifying if there is major deviation.
So first thing we do is that we sanitize our hands.
Yes, I will sanitize my hands.
Then we take the syringe and the needle. We take the syringe first
Yes.
and we open it. We open it and we see to it that we don't touch the tip.
Yes. Okay.
Then we take the needle
Okay.
and then we open that and we see to it that we don't touch again.
Okay.
Then we withdraw the amount of we decide how much drug we want and accordingly we have that air inside
Air
the
inside the syringe. Suppose we want to withdraw 2 air. Okay. We will remove the
we remove the cap.
air.
And then after we remove the cap and we withdraw the amount of air, we put the air in the syringe.
Fine.
In the vial, yes, in the vial.
Okay.
And this will create a pressure, positive pressure.
Yes.
And once we do that, then we withdraw the drug from the vial.
Now, use your side.
So this was formulation which was done, and now the fourth stage, which is known as performance. Okay, so this is where the learner will perform, student will do it and describe each step.
You have to also discuss.
Okay, so now I sanitize my hands.
Yes.
Then I take this.
Good. Yes.
Then I remove the cap and then I take the vial.
You forgot one step.
Oh yes. We had to withdraw the amount of drug that I needed and now we have to put the air inside. Then I have to establish amount of air. This is for positive pressure,
Yes.
isn't it?
Yes. You have to make sure that the needle is inside there.
That is the reason.
Yes.
Then I withdraw the amount.
Okay, so that was that. Thank you, Dr. Bhattoti, Dr. Ashray, thank you so much. Okay, finally, communication skills. Communication skills is, of course, at COM, you will have an entire session on it. Just one thing that in May 1999, Institute of, then it was known as Bayer's Institute of Healthcare Communication, Federal Institute, they organized conference on communication in healthcare, and 21 leaders from major medical education and professional organizations were invited. It was held at Kalamazoo, which is a city in Michigan, USA. And hence they came up with something known as Kalamazoo Consensus Statement. And it describes essential steps for communication in medical encounter. So if you see one medical encounter, history taking while you're seeing a case in the OPD or when you're seeing a follow-up case, usually each encounter should have these 7 essential steps. So build a relationship. What happened? Something of that sort. Open the discussion. Gather information. This is your clinical encounter. So then you ask about everything, the entire history taking, chief complaints and past history and everything. Finally, understand the patient's perspective. You want to ask them that, so now what are your concerns? So a lot of times concerns may not truly be health related. A lot of times they can be social, familial, that I have lost my job, to, what will happen if I have, how will I take care of my kids? So there are many concerns. So you want to gather information and then you want to understand patient's perspective. These 4 steps are when, in a way, the patient talks, right? Now comes the 5th step where you want to share information. What I think you have is, right, probably I'll share. Reach an agreement on problem and plan. So આપણે તમારી આ તપાસ કરાવીશું, એના માટે અહીંયા જવું પડશે, અથવા તમને અમે દાખલ કરીશું, we'll give you medicines or we'll operate upon you, something of that sort. And reach an agreement. You have to have the consent. બરોબર? ખ્યાલ આવી ગયો હું શું કહું છું? They say yes. So that is it. And finally provide closure. Is there anything else I can help you with? Do you think કંઈક બીજું રહી જાય છે આપણે વાત કરવા માટે? So that there is a complete conversation. As I told you earlier, communication is a huge subject, different, but this is what are essential 7 elements in a single encounter. Finally, team skills, very difficult to teach, even more difficult to assess. So learners are usually placed in a simulation. The same way there was a simulation that I told you, there is a simulated environment of a road traffic accident. The same way you can create another simulation whereby students are packed in bunch and then they are sent to address that issue. They are passively observed and multi-level feedback is provided. So this is about team skills. So these are my references. For anybody who's like even marginally interested in medical aid, then this is a very wonderful. Dr. Tejinder Singh is a huge name in medical education field in India. He's a practicing pediatrician, right? So it's a myth that clinicians cannot be medical teachers. Most clinicians, most people who are at the forefront are clinicians. Anyways, so this is a wonderful brief introductory book, and this one is a in-depth but a very, very pretty nicely put book. So these two is just a personal recommendation. That's it. Thank you so much. I appreciate it.